All right. Well, good afternoon if you're on the East Coast. Good morning anywhere else in the US and wherever you are. Just thank you for joining us this morning or afternoon. My name is Brandon Garrett. I'm with the National Minority Equality Forum. I'm joined today for this. I'm very happy today, not for the reason, but I'm happy that we're able to have this conversation so quickly. Our very own Mia Keys. Well, I say our very own, but she's been
I
with us.
know.
Mia will lead this conversation on the importance of DEI in medicine. Mia is really good to lead this conversation because we know she's at Hologic right now, but she has
Yeah.
worked with us at NMQF. She has worked in Congress on these very issues, and she has worked with the AMA in this space. So I'm thinking, Mia, thank you for joining us as a very knowledgeable person who can work on this issue. We also have our very own Dr. Gary Puckrin, he will stat you to death and give you the historical reasons why everything, and that's what we need to know. We need to know the reasons why, and then for more than anything, practical reasons, how the workforce is. We have Dr. Yolanda Lawson, president of the NMA, former policy chair of the NMA, a Texas physician, an OBGYN in Texas. And I think everybody on the call knows what that means and how hard that is alone, but then having all those other titles and work to do. And so I know I took a little bit of what Mia's going to talk about in introductions, but I just want to make sure I acknowledge the work that everyone here is doing in this very, very important conversation of what's happening right now. So Mia, I'm going to turn it over to you and let you lead.
Brandon, thank you. And as always, thank you to the NMQF for just always holding timely, critical conversations. We have a limited amount of time today, and certainly the scope of the discussion is more than an hour's time. But I want to ensure that we've got that we jump right in. And so I'm going to pass the microphone to Dr. Puckrin, who's going to just lead us through some slides to essentially talk foremost about to the audience today and those who are going to watch later on, for what reason is the NMQF around? For what reason, Dr. Lawson, was the National Minority, or excuse me, for what reason was the National Medical Association birthed? So I'm going to pass it on to you first, Dr. Puckrin, and then we're going to get into our conversation.
Great. Thank you, Mia, and thank you, Dr. Lawson, for being here with us. Unusual for me, but I'm going to start us off with a few slides this morning because we've got to have context for why we're doing things here. And I'm going to put this DEI conversation in the context of an emerging market, understanding a little bit about the past and understanding of the future and why DEI is so important. This is a slide that I always like to start with. This is a slave family, a former slave family, right after the Civil War. The clothes on their back, they did not own during slavery. I just want to be clear. From whence we came, right? This is the history. This family did not own anything by law, right? And so I always take a look at this photo because it reminds me of from whence we came. I just pull this because it was illegal for Black people to go to a library. Right? I mean, you could not go to a library, and Ethel Sawyer was arrested for sitting in a library. Was sitting in a library in Mississippi. And that is the context. We could go deeper into the history of the work that the National Medical Association did on the whole medical civil rights movement. But the point is, that's the past, and what DEI is trying to inform is that past. The other thing now, moving us to the future, is really the demographic shift. This is the craziness that's driving America right now. In the 1960s, 85% of the US population was white. By the time we get to 2050, it will be 47%. They are the minority. Hispanics by 2050 will be 29%. Blacks will be at 13% and Asians 9%. That's the emerging market, right? Because historically, healthcare in this country was really modeled around what was happening in the white population, because African Americans and Hispanics did not even have healthcare, really, a large percentage of it until the Obamacare. I call out this age cohort number for you because this is age 18 to 24 in 2022, 50% of that cohort is white, 24% African American, I'm a Hispanic, 14% African American. Why am I showing you those numbers? Because this is your workforce. These are the folks who are going to go to medical school, nursing, pharmacy. And if you're telling me that 52% of the population is going to carry that burden, and the numbers are going to change as we get towards 2030. So this is not even a static number. So you got to do DE&I. I mean, just the demographics, what it says. But let's take a look at the numbers by state. California, Nevada, New Mexico, Texas, they're already majority minority states. The majority of the people in those states are minority. Coming up in the before this decade is over, Arizona, Georgia, Florida, New Jersey will be majority minority states. By the time we get to 2030, New York, Louisiana, Alaska will flip. Right now, in 18% of the states, 40% of the population is minority, right? And so at NMQF, when we look at these numbers, we realize that we have to move away from the segregated rationing healthcare system that existed at the end of the 21st century. And we talk about mitigating patient risk for all patients, keeping them out of the hospital, keeping them out of the emergency room, following the science. And that's part of what DEI has to help us do, learn and make sure that we're able to provide care to a diverse population. This final slide here is really to call attention to the fact that there's an emerging drug market. We did this slide back in 2014, I'm sorry. And what we were saying there is, if you started a clinical trial in 2014, by the time you got to 2030, the majority of the people who are going to use that product are minority. That's why you have to have clinical trials. That's why you have to have diversity in clinicians. It's a complete remodeling of the healthcare system in the face of the demographics. So DEI starts to redress stuff that happened in the past, but DEI is now important as we move into a different kind of healthcare system that is completely diverse. And you can't beat the numbers, and the Supreme Court can't change the facts, right? They can make it difficult for us. They can fail to acknowledge the change. The state legislators can write all the rules they want to, but the demographics are the demographics, and the change is upon us. Turn it back to you, Mia.
Dr. Puckern, I love how you just give information and then you really just say, okay, mic drop, and then we are able to move on, not only with the question at hand, which is, what is the significance of DE&I in medicine, but you have really laid out in a lot of ways, the necessity from not only a value proposition, but really for the continuity of the nation in so many ways. And I'm going to come back to that at the end of the conversation. So thank you so much. Dr. Lawson, why does the National Medical Association live? Why was it born?
Thank you. Thank you all for having me this morning. I think that this is such an important issue. I have received so many calls in the past few days of physicians of color quite disturbed by these DEI attacks and these efforts to reverse the progress we've made. So the National Medical Association was founded in 1895, but that was after a long, extensive, and intensive struggle by African American physicians to gain admission into the American Medical Association, other constituent medical societies. And people ask, why was that important? Well, education of physicians is important. And also many times it was tied to getting and gaining hospital privileges. So it was important to become a part of the organization. So that struggle lasted a long time. And I often quote Dr. C.V. Roman, the 5th president of the National Medical Association. I'm going to read this to you. So while not founded on racial exclusiveness, the National Medical Association was certainly founded as a direct result of the racially exclusive policies of the all-white medical associations and societies. And so I often think about Dr. C.V. Roman. He was the first editor of the Journal of the National Medical Association, but he talks about that we were not conceived in the spirit of exclusiveness of race. And so when you think about these proposals that are put forth, right, our very existence, right, came out of necessity.
Same question for you, Dr. Puckrin. Why does the National Minority Equality Forum exist?
So there's been a long history in this country of African Americans, Hispanics, and I would even add poor people not getting access to quality care. You know, everybody knows I'm a historian, and I understand the founding of our country. And in the founding of our country, there was a social contract. We're unusual in that we have a social contract. Jefferson reminded us of that contract in the Declaration of Independence. We talk about life, liberty, and pursuit of happiness. Actually, the original language was conservation of life, was the original language. And so what we agreed to is that we would take care of each other. We would not discriminate and pick winners and losers. But we ended up with this segregated healthcare system that's picking winners and losers codified by our courts, which is even more ridiculous, right? And so NMQF is pushing back on that. We're just saying enough is enough. The legacy system does not work. It doesn't even work for poor white people, let alone African Americans. If you go look at the numbers in the rural community, you've got a rural community that can't even reproduce themselves. They die so quickly, right? So let's be serious about what's going on. And so NMQF is really founded on the fact that we can actually take care of each other. If we really set our minds to it, we can do that. And so that's what drives us here.
So Mia, I wanted to piggyback off of what he says. So you're asking us why we were founded and why we exist. And so when you think about entities, whether it's the NMA, NMQF, and others, the reason we have Black doctors, Black pharmacists, Black nurses, Black dentists, right? The reason they are in the workforce today is because of entities such as the National Medical Association. The reason we have students and residents at majority institutions is because of the work of the National Medical Association. And so I could sit here and I sit down this morning knowing we were going to have this conversation. And I started just writing down just on my tablet right here, all the things and all the conditions whereby we have disparities. Infant mortality. Black babies are 2 times more likely to die than white babies. We all know the numbers with maternal mortality. Black women are 3 times more likely to die than white women. Diabetes mellitus. We are twice as likely to die from complication of diabetes. Heart disease. Black people in the United States are more likely to die than any other ethnic group in the United States. Cancer disparities. We have the highest mortality rate than any other racial ethnic group when it comes to cancer deaths. I wrote down prostate cancer. Black men are twice as more likely to die. HIV disparities. Black men who have sex with men, 1 in 2 chance of developing HIV. The homicide rate, 10 times higher in Blacks than in whites. And so African Americans are disproportionately impacted by almost every disease state, other than those with a genetic basis than other races. So when you ask why, I hope that we have framed for you and that our audience today understands the why, because this is even more and now at this point greater than us as our organizations. This is any person of color in this country, right? Stepping up to the plate and understanding this impacts you in your household, in your community.
You've
So
laid
I
it
had to
very
get
well.
that off of my chest.
Listen, I am folding my hands so that I don't jump about and be disruptive to the flow of the conversation. what do we mean by DE&I in general? I mean, I don't want to assume that everyone knows what diversity is, what equity is, what inclusion is, and specifically, what do we mean by it in medicine, Dr. Lawson?
Absolutely. And so I'm so happy that you asked that question, because I think we are in a time now where there's a reframing. And so if you look at the proposal by Representative Murphy this week, it was this reframing around colorblind, right?
And
so
by the way, we're going to, audience members, we have that in the chat, and we're going to dig through that a bit more too after Dr. Lawson's comments.
right.
Pardon me, Dr. Lawson.
So we know that there are historical facts, there's evidence, and there have been occurrences that racism and discrimination exist in this country. And Dr. Puckrin started us out just rooting us around what that's looked like historically and where we're going. And so when you talk about diversity, we're talking about beyond, and that's why I think the term DEI, there's diversity, there's an equity piece, right? Everyone having equal footing, there's the inclusiveness piece. Now we're using terminology, belonging, right? And so diversity, while it's been reframed as something else, it really means that you have diverse and people from different backgrounds, places, communities, where we all represent a whole. And so I think that as we discuss this and as we go into this discussion a little bit deeper, I'm glad that we are thinking about this in the context of medicine, because we know that when I talk to you around disparities of health, you also think about the disparities around the workforce, right? So even when, and so I was at a meeting yesterday and they talked about, oh, it's going to take 100 years to get to racial concordance, where there's enough Black doctors in this country to take care of the Black population in this country, right? And so I sat here and I think, we were formed in 1895, and this is longer than 100 years, right? We're still not there, right? We're still not there of getting this diverse workforce where you have people of different cultures, backgrounds, and ethnicities that match the population of America. And so I'll let you chime in, Dr. Puckrin, but that would be my thoughts around.
So when I think about diversity, DEI, one, I think about it as redressing a past that where inequities were tolerated by law and custom. And people forget that I think NMA, the American Medical Association, began letting Black doctors in the 1970s, right? Under the gun of the federal government, quite frankly, right? And the system that was set up, the American healthcare system that exists today, really gets its footing in the 1940s when it was okay to discriminate. And so, and also in the African-American experience, I was the first generation that could go to graduate school in any numbers, right? I mean, it was the exceptional African-American, really exceptional, brilliant, right? Not ordinary folks like me who got to go to graduate school. And so it's trying to address that, but it's also looking into the future. I mean, you're not going to have 52% of the population providing healthcare to everybody. I mean, it's not going to work. And so I think part of our problem is that our political leadership is not preparing us for our future. We are a multi-ancestor, middle-class democracy. That's what we are. Not a billionaire oligarchy. It's a middle-class, multi-ancestry democracy. And healthcare plays a very important role in keeping everyone healthy and keeping the economy running and all of those things. And what I say to my industry partners, some of you folks are going to wise up and understand what that new market looks like, and you're going to beat a lot of folks out because they're spending their time in the 20th century, and we're trying to get on to the 21st century. So I think the numbers are the numbers. I think that's where our future lies.
You both have made really very cogent and clear, not just arguments, but you've laid down the facts. And I do want to spend some time talking about the Murphy bill, but I want to stay within the range right now of medical curricula, right? So Dr. Lawson, what do current students, medical students, actually gain from a DE&I infused education in medicine? And what do their prospective patients also gain by being cared for by someone who has come up in a medical education that really where DE&I are the core tenets? And then also, what do prospective patients, what harm do they potentially face if they're not being cared by someone who's been schooled in such a way?
Absolutely. Thank you. So when we talk about this from the perspective around medical education and our students, you know, studies have been done. We've seen this whereby when students are in that environment, right? When they are in the environment, whether it's other students that are different, of course, patient demographics, many academic institutions may be in cities where no matter if you're training in medicine, you may see diverse populations, but we can't guarantee that's all, right? That's all institutions nor hospitals or universities. And so we know that diversity makes them better doctors, right? When you build that into the framework of education, because much of the piece with being a great doctor and a good clinician is the communication piece, right? Cultural competence, cultural humility, cultural respect have to be embedded into those educational processes. And much of that comes from the work done through DEI efforts, right? So those efforts frame and help enhance that medical education continuum. In regards to patients, and you talked even about the harm piece. So as we think about patients, as we think about the pursuit to eliminate healthcare disparities and ensure people are having, achieving health equity, this opportunity to gain and have your optimal health, when you think about the training piece, right, that perspective and that lens for our residents, our early career doctors, and even our students, right? Because now, right, there's a clinical portion of medical school even. And so from my perspective, if they don't have that embedded in the framework of their educational curriculum, it's a loss, because I'll tell you many times, and we are required to maybe take an implicit bias training. It may be a 2-hour course, right? So some states may do that to require your medical license. Some hospitals may do that to require you to get credentialing. But does anyone here really believe that a 2-hour training course, right? That a 2-hour training course is going to allow an individual right, to ensure that they have expertise around implicit bias. And then now you're looking at states such as Florida and Texas, right? And so where implicit bias training now has come to question, or is being banned, or is no longer endorsed by institutions. And then here you are now talking about stripping away, well, here you've stripped away DEI offices, right? And so it's becoming more and more difficult to embed those principles into the educational process. And so absolutely there is harm to our minority communities, because we would not have had to do this, as Dr. Puckrin alluded to earlier. This came out of necessity, right? Historical necessity. And so unfortunately, if we were in an ideal world and if we existed in utopia, none of this would be necessary. And so my concern, my disgust, is that this is not recognized or acknowledge. So Dr. Puckrin talked about the future, but I think that also requires acknowledging the past.
It's the entire continuum.
It's the
I could not have asked for a better answer
Yeah.
from you, Dr. Lawson. And a similar question for you, Dr. Puckrin. You actually alluded to it a bit. You know, the NMQF does a lot of work with industry. What do industry leaders stand to gain, and what do they stand to lose if they're not leading with DEI philosophies?
You know, one of the things I want to clarify as well, because I think it's really important. So DEI has gotten racialized, right? And we're failing to acknowledge that we're talking about equality for women, equality for people of various religious beliefs and sexual orientations. That what we're talking about is making sure that we have a level playing field for everyone in society. And some people are uncomfortable with that, and they're masking it by, because we were always the whipping boy. We were doing it for Black people. No, we're not doing it for Black people, right? We are doing it for everyone. And I think that's a critical clarification that needs to be constantly brought in front of, because it's the inclusiveness of DEI that is what we're saying. And on the industry side, it's just good business. I mean, you know, it's good business to have a diverse workforce. It's good business to reach out to a new market that's emerging. I was at a conference in Europe a year or two ago, and they had African countries there and countries from Eastern Europe, and they were talking about themselves as an emerging market. And I said, well, America's an emerging market. And they burst out laughing, and I was like, no, it is emerging, right? And that's the point. And so what we're saying to our industry partners, look at the vaccine rates. Let's take vaccines, for example. We have under-vaccinated minority populations. I'm going to take the Medicare program since the 1990s. Ain't fixed it, right? So you get the demographic shift, and what's going to happen? You're going to lose market because you're not vaccinating that population. We did a study on hip replacements. This is about 2007. And we were asked to do a study on hip replacements, and we chose California. So in the 1990s, 80% of the hip replacements in California were done on whites. I think they were about 67% of the population. Get to 2007, there are 49% of the population, and 80% of the hip replacements were still being done on whites. So you know what that means? That means you lost market. It means that people who needed hip replacements in those communities were not getting it. That's the business model. If you want to expand your market, these are the communities where you got to go and figure out how to get them access. And D&I will help you, because guess what? You'll hire people who have that life experience in those communities that can help you reach out and open those markets up. You'll have clinicians who can go into those communities and understand the culture and live the experience with those communities. D&I is incredibly important to America's future. I know we got a bunch of Luddites and people living in the past, and they do what they do, but they're lost because that's certainly not what the future looks like.
I'm going to come back to that later on, Dr. Puckrin. So let's put a pin in that, and particularly that last part you mentioned in terms of people who are living in the past, because to some extent we have to put ourselves in their shoes, and I want to talk about that a little bit. But many of you have come to the conversation today because in terms of the audience members, because you've recently heard of the bill that's come out of the state of North Carolina, presented by Dr. Gregory Murphy. He's he has introduced the Embracing Anti-Discrimination, Unbiased Curricula and Advancing Truth in Education Act. It's just colloquially called the Educate Act, and it calls for the banning of the so-called race-based mandates at medical schools and at accrediting institutions. The main tenets of the bill really harken back to the Civil Rights Act of 1964, as well as the Higher Education Act of 1965. And it calls for an amendment to the Education Act such that if any institution carries out any type of DEI curricula, that their federal funding be stripped. Now, we know that the federal process is democratic in the sense that such a bill has to be presented to his colleagues within both chambers and debated, and then potentially be shot down or potentially become law. The fact, however, that it is even allowed to come to the floor, or rather is allowed to be presented in Congress because there's some sort of appetite across the nation is disturbing. But it is not the first time that such a bill has come to pass, right? It is not the first time that these conversations arise in the public consciousness. It happens often. And so I want, I'm hoping Dr. Lawson and Dr. Puckrin to just briefly talk about those times in history where we've seen, including now, we've seen public pushback to, equivalents of conversations around DEI, whether it be particular to medicine or just in general. May you describe to us like the state of the nation of those times? Who were dissenters? Who were champions? Talk to us about those, please, those issues.
Sure. I'm just going to briefly comment on this as I have to transition off of the call. I apologize for that. But so we know that the DEI field grew out of the 60s, right? And so when you think about that, it began to expand to include not only race, gender, sexual orientation. So we've seen not only the evolution, but those other categories, right, I'll say, that have benefited from the DEI movement. So we saw some transition again in the 70s and 80s to integration in the workplace. We just talked about integration in education in schools, societies. You just heard Dr. Puckrin talk about the integration of AMA allowing Black physicians into those societies. And then you began this around multiculturalism and awareness. That's late 80s. And then we get into the 90s to present day. And so I'll tell you, after George Floyd's death, corporate America, so many entities stepped up around their commitments to equity, right? We began to hear more than I've heard in my entire 20-year career around the focus around health equity, around inclusiveness. So, it really was amplified. And I'll be honest and vulnerable with you today. I was concerned then about the backlash, right? So while it seemed great, what I was most concerned is about the backlash. And so this effort, as we think about DEI and what it means now, I talk about this often. A senator told me, Yolanda, choose your words carefully. You should use fair and just. You have to take even the word equity. And so we now are faced with these terms and now triggering, right, to others. And exclusive. And so I think that as we think about this evolution and where we are in this day and age, I took hint, right? I'm using terms such as fairness and justice because that's what we're talking about, right? These DEI efforts were put in place to ensure fair and just practices. And as Dr. Puckrin mentioned earlier, it took government intervention to get us here. And so I pray, do tell, it's quite concerning. As an organization, we will be speaking out around this. We'll be written, and we're actually planning some other visible press conferences and other events. I'm also looking around who are our partners, right? I think you brought this up a little bit earlier. Who are the other partners? Making sure people are aware. I'm also concerned, Mia, everyone's not aware of this. Even when you talk about physicians. So I'm taking on that role to make sure, because it's not even what I do at the national level. Some of this is also going to be state driven. So we have to organize even at the state level.
especially that last part there, Dr. Lawson, and I know you have to go, you actually have patients to attend to, and we really appreciate your space and time. But you are so correct in terms of, government intervention, and it cannot just be that we see interventions and bills that would help to pivot the conversation on the local, on the national level here, but state medical societies have a role to play. If you all who are attending this conversation are members of state societies, talk to your leaders there, speak with the organizational boards, and ask them specifically, who are you partnering with? How are you engaging this conversation? For what reason are you or aren't you in a part of the conversation? And what's at stake if you don't attend to it? I couldn't say more about that. Dr. Lawson, any final words before you need to head off?
Not at this time. I thank you both for this platform, for this space to discuss this. It's been a challenging week, and I look forward to anyone partnering with me to amplify and work on these efforts. So thank you, Dr. Pucker, and thank you to NQF.
Yeah, thank you, Dr. Lawson.
Thank you, Dr. Lawson. For those of you who wish to be in touch with the NMA through your own organizations, or you yourself are a physician, and if you're not active on the state level or on the national level, I certainly implore you to become active. And if you're looking for contact information, we can drop the necessary contact information in the chat. Dr. Puckrin, what I was also picking up from Dr. Lawson is that this is tiresome work. Right. This is exhausting work. It is also distracting work sometimes, right? But it's necessary, especially because the way you frame the conversation is that it's not just about what's happening now, and it's certainly about what has happened before, but it's about the future. And one cannot look toward the future without a bit of optimism, but certainly not without strategy, right? And so in terms of advocacy and strategy around, championship of fairness and justice, right, and DEI work, who are those people, who are those organizations, or not even so much organizations, but paint for us a picture. Who are the historical allies, and who are dissenters, and how and why would people dissent against such tenets?
One of the beauties of democracy is that everybody has a voice to push forward their ideas in the public square. And then we all get a choice about whether we accept them or not. One of the roles that African Americans have experienced really from the founding of the Constitution, I think of them as the Democratic vanguard. We were at the vanguard to make sure that pushing the country towards its ideals, to perfect the experiment. The women's movement came out of the African American push against slavery. African Americans in the Jewish community worked together on religious discrimination. African Americans have been part of the efforts in the gay community. We're always trying to make sure that we're pushing the envelope and really helping the country live up to its ideals. Medicine has been an interesting space. It was deeply linked to segregation and rationing and all of that. It went through some remodeling when Medicare program came into place, with hospitals being desegregated and medical societies and practices being forced, if they were going to accept government money, to desegregate, so that veneer was taken away. But deep down in the system, some of that inequities were tolerated and explained. And now what we see is, in fact, the way I put it to you, Google the earth is flat. There's a flat earth society out there. There are people who gather, right? So, if people think the earth is flat, there are going to be those who think that DEI is some bad thing. I'm very confident that it's our future. And that confidence sits squarely on the demographics. Demographics are destiny, and you can't change that destiny. And so it is upon all of us as public policy to make sure that we vote, that we express our opinions. I mean, if you're supporters of DEI, you can't reward those because that's what they're looking for. They're looking for that reward for their ideas, and understanding that in rewarding them, you're just making the path more difficult to accomplish. And I think that's where the National Minority Equality Forum fits on this. We realize it's not going to happen overnight, and that's interesting for me because when I was growing up, we used to call those who didn't push hard accommodationists and call all kind of bad names. They weren't moving the frontier quick enough when you're young, right? You can do that.
And now you've wizened a
Yeah,
bit.
now I've gotten wise and understand that this is a complex system that has many parts to it, both in terms of interest and the way in which healthcare is provisioned. And so it's going to take a moment to move it along. We need to claim ground and not lose ground. And you know, to your word, being very intentional about how we want to build that future.
And that's not to say these issues aren't of great urgency. Yeah, and it's not to say that we shouldn't hasten to the moment with deliberation, right? And you know, it's fascinating to me that these things are in a lot of ways cyclical. And you know, whenever there is major influx societally, there's extreme pushback from the status quo, right? We've seen that over and over again. We can offer all kinds of examples. But you said something that I want to pick up on, and it goes to a question that is also presented by one of our audience members. You know, post-COVID, and then post all of these decisions coming down from the judicial arena around DEI efforts in education, we saw the succinct removal of Dr. Claudine Gay from her position as president at Harvard, primarily because of comments made around or so-called anti-Semitic comments that she made, right? And her really being quite staunch that she stood by freedom of speech for her students, right? And that wasn't an easy thing. But what that also demonstrated, I think, to a number of people who are attending this conversation is that even people who have been past allies, and you spoke about finding common ground between African Americans and Jewish people in America. It's really difficult for a lot of people who are Jewish, and I hear people who are some friends or colleagues or mentors who are Jewish say that they are uncomfortable with conversations around DEI. But the thing is, when they're uncomfortable, there's also still a power structure that can move in accordance with their discomfort. It's not the same in the same way for African Americans. So how do we really put out a cry to people who have been allies historically, and this is not just people who are Jewish, but historically have been allies, but are not necessarily attending to the DEI conversation in the same way or with the same sense of urgency as Black and Brown folk? Yeah. What are they hearing when they hear DEI, and what is keeping them from coming to the to the front lines with us?
So some of it, I suspect, is you're going to take something off my plate by bringing diversity in, and I think one of the things I'm saying, when you look at the numbers, that's not going to happen. The plate's too big. You can't provide care to 300 million people, right? Just out of a select group of clinicians, nurses, pharmacists. We all have to work together. Part of this American experience has been alongside of the democratic push has been this idea that we need a privileged class and that the society can't work without a privileged class. That's a myth, right? It doesn't have to work that way. But you need leadership, and it's a challenge, right? Because if you can make people angry enough and others somebody, you can get elected, and that just creates more look like you. But that's not what the society is. The society is a multi-ancestry population. Everybody, at least outwardly, expresses commitment to the social contract. And being able to train, educate, and give jobs and take care of diverse populations, that's our future. I mean, I don't know how else to say it. We're not going to be successful if we decide that this is too hard for us. We want to retreat back into the comfort of our little segregated space where we don't have to acknowledge the reality that's sitting in front of us. I think that is the challenge.
That is a major challenge, right? And for a lot of us on the call, there is no option of retreat, right? For a good number who are on the call, perhaps there is option to retreat in the sense that, they can say, well, we don't know the language, we don't know how to operationalize equity, we don't, or we really just want to focus on, the whole colorblind ideology. But what about those who are consistently on the front lines? What kinds of protections can employers or academic institutions potentially put in place to ensure that that their champions of DEI are protected, are valued, are incentivized to remain as they are, and not in a token way, but in a really very transformative, meaningful, valued way? That's a big question.
Yeah, it is. Look, D&I is a process of strategy for a time, for a moment, right? I mean, the ideal is when we perfect our American experiment, that you don't need D&I, that it's a society now that recognizes and treats everyone fairly and equally. But that's not where we are right now. That's not what we're transitioning from. And so I'd make this comment to the business community because I've come to appreciate that deep social change happens around business. And I'm saying a couple of things to business. If you decide that you're not going to use D&I, the cost of your labor is going to go up, right? Because you're going to be competing for a narrow pool of people who can't meet the demand. And so supply and demand, the cost is going to go up. And so not taking advantage of populations who could be physicians and nurses and pharmacists and all that will drive your cost up. You're also going to have trouble opening up new markets, getting into the market, because there's going to be a lot of business for the fact that the system is not allowing people to reach their potential. More broadly, the society is not going to function very well. Middle class is about social equality. It's about, if you go and read the early democratic thinkers, they were tremendous social engineers. They understood exactly what they were building and what it took to maintain social cohesiveness. And where they landed was the middle class was the stability element in the society. It's not the oligarchs. They want to pull us, billionaires, they want to pull us into a direction that denies democracy at the end of the day. And obviously, it's not very poor people, because guess what? They're rebelling against the social order because they're poor and they're not getting what they need. And so the stable framework in the society is the middle class. And if you go look at our numbers right now, we're not building middle class. I think that's what Biden is talking about. We're not building middle class. And so we've got all of this unrest and challenge, and DEI is part of that unrest and challenge.
Couldn't get to my unmute button fast enough, Dr. Puckrin. But I wish I could have just in real time penned a good number of what you just said, because this is a large issue, right? I want to speak. So you've taken time to speak to corporations. We've taken time today to speak to medical institutions, and we've also alluded to why hospitals will really need to receive physicians who have come from a medical background that is really enhanced by DEI. Talk to us for a moment, Dr. Puckrin, about from the perspective, because you said it just for a little while, from the perspective of those who dissent. You said essentially that they feel like the pie might not be big enough. But if that is their perspective, how does that play out on a day-to-day basis in terms of what businesses look like, what the future of medicine can look like? And then also, how is it that people who do not lead that way, how can they really rally together? Who do they need to be in touch with legally, through policy processes? Where are their gathering spaces for not just cohesion and safety, but activism?
I think we have to resign ourselves to the fact that there are always going to be people who are anti-DEI, anti some other group. You're never going to wash that out of society. Once an idea takes hold, it's almost impossible to get rid of. But it's not the getting rid of that's important. What is important is, what does the majority of Americans think? What is the majority of Americans willing to vote for? Because that's what a democracy is. We all get to cast one vote. And this takes me back to the demographics, because the majority of the people will be people of color, people who have experienced the short end of the society. And what we want them to think about and do is to say, we are a community, we're a family, we're going to take care of everybody. No need to push and shove. Everybody is going to get access. Everybody is going to be able to maximize their potential. And I deeply believe that we can do that. That is the American experience. And there'll be, people sitting on the sideline throwing rocks. But if we keep our eye on the ball, be very intentional, and be there in the moment when those people who are throwing rocks need help, I think that's transformative. Look, medicine, we're in the middle of a medical revolution. Just incredible science, hampered by the fact that we can't get that science provisioned out to all of our communities. All of those inequities that Dr. Lawson enumerated, they're all fixable. There's not one of them that we can't fix at all. And so we're saying that it's in the interest of all of us. It's our social contract. It's what we agreed to. Let's focus on that. And I think that's That's why voting matters in a democracy, because anybody can put forward any bill that they want to do, right? And we should encourage that. But that doesn't mean we got to vote for it.
It's really that vote that's truly pivotal, right? And
Yes, absolutely.
completely. And I won't assume that everyone who's listening to or watching this webinar believes in the democratic process, right? I mean, I know elders who have been who have disassociated themselves from the democratic process for a long time, and to hear them tell it for good reason, right? And they're, however, that aside, you're saying ensure that we do not reward those who stand for something that goes against our own survival and thriving. That sounds really very basic, right? But it's not just voting. It also matters in terms of, do you know your member of Congress? How frequently are you calling that member's office to speak to their staffers? So for, I'm not going to call out any particular names, but for any bills that that are important to either pursue or to raise, you should be in touch with that member of Congress. Say, call them and say, I want to speak with your staffer on X, Y, and Z subject. I would like the email of said staffer, and express your constituent concerns.
Let me say it back to you this way. Public policy is a branch of medicine.
I knew you were going to, I was trying to lead you into it.
It is a branch of medicine, right? We may not recognize it as such, but if it's not provisioned by public policy, you're probably not going to get it, right? Particularly as, the unusualness of the healthcare marketplace is that we have to have insurance and bundle out collective risk and share resources in order to make sure that at times of need that care is available. And so that's all about the vote, right? It's people didn't want to have Obamacare, right? They were mad because he gave them health care until they got it, and they said, "Oh, well, this ain't too bad," right? And then you got people running around saying, no, we need to get rid of it, but they can't seem to get enough votes to get rid of it. Same with Medicare, right? I mean, nobody's thinking about seriously doing damage to that. And that's the point. Mm-hmm. The point is that you build strong coalitions to make sure that we're being inclusive, we're being equitable, and we understand the need for diversity.
Yeah.
And folks who want to speak up against that probably don't live in 21st century America. They've created a space for themselves that doesn't really fit the reality of 21st century America. And so we're on that journey. No one said it's going to be easy. But I'm absolutely confident that we will get there because there isn't another pathway.
And I stand with you there, Dr. Pucker, and I stand with you hand in hand in the front lines with respect to strategic optimism and strategic, really just grounding ourselves in what we know to be true. And you laid out, what's the demographics don't lie, right? But at the same time, for those of us who are fighting, and in the sense that, every day seems reactionary, you're watching also the political pulse in terms of what's coming out of different policy camps. You've got to have a strategy of, raising your voice when bills like this Murphy bill come about, but one cannot keep their entire energy there. It's draining, it's exhausting. In the words of Toni Morrison, it's also distracting, right? And at the same, please.
Yeah, I'll take you back to Ethel Sawyer's sitting in a library in Mississippi, right?
Yeah.
Where she was lucky to get arrested and not killed.
Yeah.
Right. But did that because she knew that we had to open up those libraries and desegregate them. There was a medical civil rights movement in the 1940s, was part of the March on Washington. We don't talk about it a lot, but there was NMA and others were out on the front line breaking down those barriers. And for African Americans, we use 1965 as the point of departure in terms of our ability to think about building our own communities. And this is just another piece of that journey. Difficult as it is. Just
another piece of that journey. You couldn't have said it better. I know that we are a minute beyond. I do just want to acknowledge, because we uplifted her name in her book during the week before last when we were talking about women's health. But for those of you who are looking for a deeper and more personalized experience, I encourage you to read Dr. Uche Blackstock's newest book called Legacy. It's essentially her journey as a Black physician. Please read that book. There are many other tomes that one can get out of the library, Dr. Puckrin. And there's so many things that I wish we could have been able to talk about today, but again, keep in touch with the National Minority Equality Forum. Do you want to tell them a bit, or maybe Brendan will come back on camera to talk a bit about the Health Summit that's coming up, Dr. Puckrin?
Yes, Brendan will do that.
Okay.
Mia, always enjoy the conversation.
It is always a pleasure, sir.
Okay, thank you.
Thanks all. Thanks so much for the conversation. Really appreciate you laying the ground. Well, always laying the ground, but we're continuing to let everyone know what's happening on the here and now as well. So mention the summit. It's our, depending on who you talk to, 22nd or 23rd National Annual Summit on Health Disparities. It'll take place in Washington, D.C. at the Watergate Hotel. We can put a link in the chat box, but it should be on the website now as well. We're under the theme, we have the data, now what? So it's going to be a really big call to action of what we should be doing to promote diversity in the healthcare workforce, diversity in medicine, and just living the tenets and the mission that NMQF has. And so that's all I have for today. I appreciate everyone joining it. Future Dr. Mia, Dr. Puckrin, and Dr. Lawson, thank you all for you done. Talk to everyone.
Thank you.
Thanks.
Good day to everyone.
Have a good one.